our staff who've all worked so very hard on this program, our planning committee, Mark Johnson in our office, Barbara Giles, she's the person you see outside to fill out your little slips for the door prizes, Joe Zapata, and from the VA, Elizabeth Packer, Veronica Salazar, and Tressa Carr. And in the back of the room, we have a stream team. This conference and tomorrow's conference are being streamed live on the internet to other folks who are listening in who couldn't be here, and that team's led by Bob Merrill, and back there with him as well are John Munoz and Kelvin Buchanan. So thanks to them. And do you want to do, okay. So
they've slipped out. Got it.
Remember to fill out the various forms that are in your book, tear them out. Oh. Do I have your attention? That's okay, that's why I was doing it now, while they're getting seated. That's okay. I don't mind if they don't listen to me. They were just the same announcements. Remember to fill out your forms.
There we go.
Okay, now we have some announcements. Do I have everyone's attention? Because if I don't, Russell will ring that thing again. Okay, remember to fill out the forms that are in the book, tear them out and give them to Barbara Giles outside. And remember to also sign up with Barbara for door prizes. We have some great door prizes for the afternoon. And finally, of course, thank you for visiting our vendor tables during the break, and remember to do so again at lunchtime and during the final break. So now, Russell and I are very, what?
Nothing. As we get things going this morning, I want to know, Carol, do you have any good diabetic jokes?
Well, I don't think it's a very good joke, but I'll tell it. So diabetic walks into a bakery, and he says to the baker, "Do you have anything here that I could eat?" And the baker says, "Everything, as long as you don't put it in your mouth." See, that's not a good joke, is it? Hello.
Well, did you know that I used to work for a crisis helpline? And I answered a call one day from a woman who said that she was diabetic, and she thinks she had eaten too much sugar today. And I said, "Well, how do you know? Are you lightheaded?" She says, "No, I'm brunette."
That wasn't funny either. Okay, well, this focus on diabetes jokes has to do with our next speaker, Dr. Nicolas Musi, who is going to tell us about diabetes care. And as you can see, he is the director of of several things: the Geriatric Research, Education, and Clinical Center. I didn't have that one on my list, is why I had to look over there. But he's also the Associate Director at Translational Research at the Barshop Institute for Longevity and Aging Studies. And he is the Associate Medical Director of the Texas Diabetes Institute. And he also researches molecular mechanisms responsible for insulin resistance in aging muscle. So welcome, Dr. Musi.
Well, thank you very much to Dr. Saunders and the organizing committee. So I'm going to talk about different aspects about diabetes in the elderly. In your handouts, there are several slides I'm going to skip because they deal with mechanisms of insulin resistance, and even though that's what I research about and I think it's very important, I found that in this presentations that we spend too much time discussing that, and then when we go to the clinical part, we don't have enough time. So I'll skip that. So I'm going to tell you a little bit about the epidemiology, very little about the pathophysiology. I'm going to spend more time about some practical issues regarding diabetes management in the elderly. So what this figure shows is the worldwide cases of diabetes throughout the years. And what you can see, obviously, is diabetes is increasing very rapidly. Just in the last 10 years, the number of cases of diabetes around the world has increased about 40%. So obviously, this is a very, very serious problem. And there are several reasons why diabetes is increasing so rapidly. Most of these cases of diabetes are cases of type 2 diabetes. As you may know, diabetes is classified mainly into two major categories. One is type 1 diabetes. That's the diabetes that occurs more frequently, although not exclusively, in children and young adults. And by definition, that's an autoimmune disease in which the immune system destroys the beta cells which produce insulin. Type 2 diabetes is what used to be called adult onset diabetes. We don't call it adult onset because it can happen in children as well. And type 2 diabetes is the one that is frequently associated with obesity, with a sedentary lifestyle, and that's what accounts by about 95% of the cases of diabetes in the US. So this very fast increase in diabetes is occurring mainly because type 2 diabetes. And why is it increasing so fast? Well, there are two main reasons. One is fairly obvious. As people around the world, not only in developed countries, but also in underdeveloped countries, are moving from rural areas in their farms where they tend to have lower caloric intake and very high levels of physical activity, and they move into urban areas and large cities where there's a lot more availability of food in the form of high caloric nutrients, and there's transportation, so physical activity is lower. Rates of obesity are increasing all around the world, and that's the main driving force for diabetes. But there's also a very important reason why diabetes is increasing so much, and that is because aging itself, independently of obesity, is also a very important risk factor for developing diabetes. So as treatments for diseases such as cancer, cardiovascular disease, infectious diseases that are major causes of mortality, as the treatments against these problems have improved considerably in the last few years, people are living longer. So living longer in itself, it's a major risk factor for developing diabetes, type 2 diabetes. And we can see that in some of our very older patients, that they're not necessarily overweight. They might be even thin, and they still have type 2 diabetes. So what this figure shows you is the number of diabetes, either undiagnosed or diagnosed. And by this, I mean diagnosed case of diabetes is in which the patient and their doctor know they have diabetes. But for every case of diabetes, it is estimated that there's another case of undiagnosed diabetes. Plus, for any case of diabetes, there's another case of what we call impaired glucose tolerance. This is based on a glucose tolerance test. And this is a pre-diabetic state. A person that has impaired glucose tolerance based on a glucose tolerance test has a very high risk of developing diabetes over the next 5 years or so. So what I want to point out here is that, as you can see, both diabetes and pre-diabetes increase significantly with age, such that 1 in every 2 people who are age 65 or older have either diabetes or pre-diabetes. So obviously this is a very serious problem, and we try to understand why this is happening in order to prevent it. So why diabetes risk increases so much with age? So to discuss this, first I'm going to go over some very basic concepts about the normal physiology of glucose metabolism. In normal circumstances, after we ingest a meal and the nutrients enter the gastrointestinal tract, this is the stomach and this is the gut, obviously all the nutrients get absorbed into our blood, and glucose levels start to rise, right? And of course, glucose is very important for the normal metabolism of our cells. But glucose can be very toxic if it reaches very high levels. That's why diabetes, which is by definition means elevated glucose levels, is the main cause of blindness and kidney failure and neuropathy, because if glucose levels rise too much after a meal, that glucose is very toxic to the cells in our eyes, our kidneys, and our neurons and blood vessels. So there must be a mechanism that keeps the glucose very tightly controlled. And that mechanism involves release of insulin by the pancreas. So after we eat, our pancreas releases this hormone called insulin, and insulin acts on different tissues like the muscle, the liver, and the adipose tissue to keep glucose levels tightly controlled. So one of the things that happens with diabetes is that the insulin that is released by the pancreas after we eat cannot function properly on its target tissues. So the muscle cannot metabolize glucose properly after we eat a meal, because the muscle becomes resistant to the effect of insulin. And the same happens with other tissues such as muscle, such as fat and the liver. So one of the first things that happens when in the pathogenesis of diabetes is what is called insulin resistance. And this is manifested here as reduced glucose uptake by the muscle. The liver makes too much glucose, and the fat releases too much free fatty acids. But when this happens early on, a patient does not necessarily going to become diabetic, because the pancreas, the beta cells in the pancreas are pretty smart. They can detect this insulin resistance, and they will do something about it. They'll say, okay, the insulin I'm releasing is not working properly, I'm going to release more. It can release 10, 20, or 40 times more and overcome this insulin resistance. And that person who is insulin resistant, probably because that person has become overweight and sedentary. There are also genetic factors. So that person, even though would be insulin resistant, might not become diabetic, because those beta cells are pretty strong and they can keep overproducing a lot of insulin, and that can occur for a year, 10 years, or for throughout the rest of that person's life. So actually, about 80% of people are 80% of insulin-resistant people are lucky enough to never become diabetic, because they have very healthy beta cells that can keep going. But there's about 20%, which unfortunately their beta cells will not be able to keep compensating, and this is called the defective beta cell secretion. And why in 20% of the people that are insulin resistant, their beta cells can't keep overproducing is not known, but it probably has to do with genetic factors. So for a person to become diabetic, two things need to happen. One is they have to become insulin resistant, and also their beta cells need to become defective and not keep compensating. So one of the central questions in the aging field is what happens in older people? In other words, with older people, is it because they become diabetic because their tissues become resistant to insulin, or because their beta cells stop working as people age? So just to make this long story short, and that's the part that I'm going to cut, in general, there is proof that there actually, with aging, there are abnormalities at both levels. As we age, as part of the normal aging process, the ability of the pancreas, of the beta cells in the pancreas to produce and release insulin in response to a glucose challenge decreases with age. And it's not entirely clear why, and this is a tough area to do research on, because basically analyzing the pancreas of patients is difficult, just because the pancreas is localized behind the stomach. So a lot of animal studies have indicated that as we age, or as the animals age, the number and the size of the beta cells declines. But, and there is some evidence in humans that this might occur as well, although the evidence is still somewhat preliminary. But what is very clear, and there's a lot of more information, is on the other side. And that is, as we age, our muscle becomes insulin resistant. And that's why is muscle so important? Muscle is very important because it's the main tissue that takes up the glucose that we consume, and that is responsible for both metabolizing that glucose, burning in that glucose, and storing it. And for that, insulin released by the pancreas has to act on the muscle. So why would our muscles become resistant to insulin as we age? And there are different mechanisms. One has to do with visceral adiposity. As we age, our bellies tend to grow. And actually, the adipose tissue in abdomen produces a lot of substances that actually are toxic to the muscle in terms of glucose metabolism. They release the fat in our abdomen produces a lot of free fatty acids, produces also substances that we call cytokines, which are proteins that are inflammatory, and they reach the muscle, and it doesn't allow to work properly in terms of glucose metabolism. There's also what we call sarcopenia. Sarcopenia means a decrease in the size of the muscle. So if you envision our muscles to being this large reservoir that takes up the glucose and stores it, as we age, our muscles get smaller and smaller, then we have less of this reservoir that will take up the glucose to metabolize it, and then this glucose is in the blood where it shouldn't be. The third major reason why our muscles become insulin resistant as we age is low physical activity. So physical activity in itself, it's a major determinant of insulin sensitivity. People that are more physically active, their muscles respond much better to insulin to take up the glucose and oxidize it versus people that are sedentary. And of course, for different reasons, as we age, the physical activity declines. And lastly is what we call decreased insulin action. That is, if we normalize for all these variables, that is, older people that don't have visceral adiposity, because not all older people have visceral adiposity, not all older people have sarcopenia, and not all of them have low physical activity levels. If we normalize all of this, there still seems to be a decrease in the ability of insulin to metabolize, decreased ability of the muscle to metabolize glucose in response to insulin. And this is an area in which my laboratory is very interested in. And it probably has to do, and I think that's in your handouts, with a decrease in the function of certain organelles that live in all of our cells. They're called mitochondria. They're like these football-shaped organelles. We have thousands of them in our cells, and they are the ones responsible for actually taking up the nutrients, metabolizing them, and converting them to energy. And it turns out that the function of these mitochondria declines significantly as we age, but the good news is that this decreased function of the mitochondria can be completely reverted with exercise. So we've done studies in which we have people to do aerobic exercise on a bicycle, and the function of the mitochondria can be completely reversed. So that is the good news. Okay, now, now I'm going to move to some more practical issues for you to apply as you provide care to your patients with diabetes. And one very basic question that I would like to bring up is whether should we treat diabetes in older patients. So why do we treat diabetes in the first place in anyone? You know, 80 years ago, one might say, well, what's the bad thing about having too much glucose? Well, as I said before, glucose was sugar. It's very important for our cells, right? All of our cells need some glucose to be able to conduct their normal daily physiologic activities. But too much glucose, as I said before, is toxic, particularly to the blood vessels in our eyes, to the kidneys and the nerves. So diabetes is the main cause of blindness and kidney failure and amputations and so forth. So in general, yes, we need to do something about having too much glucose around. Now, how long does it take for having too much glucose, someone having diabetes and being poorly controlled, how many years does it take for them to develop complications? 1 year, 10 years, 50 years. In average, it takes about 15 years. So, of course, this varies, and not everyone is the same, but if you take into account that it's going to take 15 years, someone might say, well, if person develops diabetes at 90 years of age, why are you going to treat them for diabetes if it's going to take 15 years to develop complications, right? So these are the questions that are out there and are part of this debate. Now, also to try to answer this question is treating diabetes, in other words, does decreasing the levels of glucose, does this prevent the complications? And the answer is yes. So there are two major studies. One is called the DCCT, which was a trial performed in patients with type 1 diabetes conducted in the late 80s and early 90s, which demonstrated that in treating patients with type 1 diabetes and improving their glucose levels decreased the incidence of microvascular complications. Which are the microvascular complications? Those are the blindness, the kidney failure, and the nerve damage. And those were decreased by about 30 to 50%. However, the macrovascular complications that are associated with diabetes, mainly stroke and heart attacks, were not prevented in that trial. Now, the other major trial in terms of prevention of complications is the UK PDS trial, which was conducted in the UK in the late 1990s in patients with type 2 diabetes, and that study also demonstrated for the first time that treating people with type 2 diabetes and decreasing their glucose levels decreased the rate of microvascular complications, blindness, kidney, and nerves by 40 to 50%. And there was a tendency, but not statistically significant, to prevent macrovascular complications such as heart attacks. So that is why we treat diabetes, right? Mainly to prevent the microvascular complications. So when we discuss should we treat older people with diabetes, these are some of the things that we know. Older people with diabetes compared to older people without diabetes do have higher rates of premature death, functional disability, hypertension, congestive heart failure, and stroke. older subjects with diabetes also have higher rates of geriatric syndromes. Those are polypharmacy, depression, cognitive impairment, urinary incontinence, falls, and pain. So this is some argument in suggesting that it might be important to treat older people with diabetes. These are some recommendations from the American Diabetes Association and the American Geriatric Society in terms of treating for cardiovascular risk factors. Should older people with diabetes be given, should be treated for hypertension? And the answer is yes. Not treating for hypertension in older people leads to very high risk of major complications, particularly myocardial infarction and strokes. Should we treat for high cholesterol and aspirin? And in general, the recommendation is if the life expectancy is at least equal to the duration of the clinical trials that have been done in this regard. So in general, if you expect that a person will live at least 3 to 7 years, it is probably reasonable to treat them with lipids and aspirin. Screening for diabetic complications. Yes, you should screen, but in generally, the screening should be individualized and the emphasis on complications which limit the function of our patients, such as blindness and pain in our feet. Now, a central question, so in general, the answer is, should we treat older patients for diabetes? I would say yes. But the other question is, how aggressive, right? Should we be very aggressive? Should not be very aggressive? Kind of aggressive? So this is some information that will hopefully can give us some answer. This is data from Dr. Espinosa and Dr. Hasura here in San Antonio, in which what they did is they studied a group of older people with a mean age of approximately 80 years old. So they evaluated them and they screened them for frailty. They scored them for frailty with a standardized measure of frailty, which includes how much how fast they can walk and certain other criteria. And based on this criteria, these people are categorized in 3 levels: non-frail, frail, or pre-frail. And then they didn't do any interventions. They just followed these people for 5,000 days. And I don't know why they plotted this on days, but this instead of years. But this, I don't know if Dr. Espinosa is here, but I always forget to ask her this. But this is, I guess, about 12 to 13 years. So they followed them for all this time, okay? They didn't do any intervention. They just followed them. And of course, these people went through their regular treatment with their primary physicians. So let's look at this. If a person is frail at the beginning, who's 80 years old, over the course of 13 years, you can see that they have a higher risk of dying. This is a Kaplan-Meier survival curve. Up here means that 100% of them are alive. And as this decreases, it means that some of them are dying. So by the end of the 12 years, almost all the patients who were frail have died. And the pre-fails are in between. But the reason I show this is that if you're 80 years old and you're healthy, you're considered non-frail. Oops. So if you're in here, you're healthy. You might have some medical diseases, but they are under control. You have a very good chance that after 10 or 12 years, about 30%, only about 30% of these people have died, meaning that 60 to 70% of these people that were 80 years old are still alive. So if you're 80, but you're healthy, you're functionally active, you still have several years to go, okay? So the point of this slide is that, sure, when you're going to decide if you're going to treat an older patient with diabetes, don't focus so much on their age, but focus on their frail status, on their function. Are they functional or not? This is another, something else that I want to show you because it has brought some noise to this argument about treating older people. And that is 3 studies that were published about 4 years ago, the Accord, Advance, and VADT. And these studies were mainly conducted in older people. Well, they were in their mid-60s in average. Most of them have type 2 diabetes, and they have type 2 diabetes for several years. And the goal was to see whether aggressive diabetes management decreased the rate of macrovascular complications, of heart attacks and strokes. And the 3 different studies were using different ways to improve diabetes control, insulin or oral agents, etc. But in general, in this population of type 2 diabetics, who most of them have had diabetes for a long time, many of them have had some cardiovascular events. Intensive glucose control did not reduce cardiovascular mortality, and actually, there was in one of these studies, there was a small increase in cardiovascular events. And aggressive A1C treatment was associated with a significant increase in hypoglycemia. So based on this, the recommendation was, and here's some more. In one of the studies, there was a decrease in nephropathy. So in general, the data from these studies, the conclusion was that aggressive treatment against type 2 diabetes in people who've had diabetes for several years does not decrease the risk of macrovascular complications and only has a small effect on microvascular complications. On the other hand, one of the weaknesses of these studies is that they started the aggressive treatment pretty late in patients that have diabetes for quite some time. So you might hear that there are some studies suggesting that aggressive diabetes treatment is not important in older subjects. But that's not, in my view, that's a misinterpretation. That what basically is telling you, if you've had diabetes for several years, if you've had cardiovascular events, it is probably not very safe to decrease your blood sugar too much. And probably the focus should be in keeping your A1C approximately at a level of 7 or 8. Now, based on this data, the American Diabetes Association and American Geriatric Society recommends the following in terms of how tight should the control for diabetes be in older subjects. So these are the things that one should consider. One is functional status. That's the most important thing, right? If a person is very functional, probably regardless of their age, one should probably aim for a tighter control. And the same goes with life expectancy. You do consider life expectancy, of course. If someone has a disease with a life expectancy that will cause a decrease in life expectancy, probably you will not be so aggressive. But a person is very healthy, you might be more. Cognitive function is very, very important. If someone has severely impaired cognitive function, it is practically impossible and unreasonable to expect a tight control, right? If someone who has a poor cognition, it is not prudent to be testing glucose levels constantly and giving insulin injections, etc. And the fourth point is what we call clinical heterogeneity. That, in other words, this means, is this person prone to complications? And this is an interesting thing because Let's assume that a person has diabetes and they have poorly controlled diabetes for 40 years. Does that person has a 100% chance to develop complications? So it only has a 50% chance. So if we take the whole room and we all become diabetic suddenly, we don't treat our diabetes, we don't care about it, how many will develop complications? About 40 will, about 60 won't. In other words, there are certain, some of us, or some people are protected for developing diabetic complications. Now, if I become diabetic and they tell me, oh, you have a 50% chance of developing severe complications if you don't treat, to me, 50% is huge. So I will do my best to not to happen. But in other words, there are people that are lucky, probably because of genetic predisposition to be, they're lucky and they are protected. So if you have a patient who just discovered they are diabetic, you discover they're diabetic, but they tell you, oh, I've been diabetic for 50 years, I never took care of my diabetes, my glucose is always high, and you check them and they're beautiful eyes, their retina is perfect, their kidneys are fine, their blood vessels are fine, everything is fine. They say, well, this is a person who's probably protected. I might not be as aggressive in this person, okay? So a person who's functional, cognitively intact, significant life expectancy, in general, you shoot for the same goals as a young person with an A1C of approximately 7. But if a person has decreased function, short life expectancy, the glycemic control can be relaxed. Now, by glycemic control can be relaxed, I'm not saying that you ignore their diabetes, right? So you won't allow that person to be walking around with glucoses of 3, 4, 500 because those patients can go into the hospital with a severe infection or dehydrated, okay? So I'm not saying ignore their glucoses, just that their glycemic control does not have to be so tight. Now, let's talk about a few things about, Mark, how much time do I have?
20 minutes.
Oh, great. Okay, so some medication against diabetes and in the context of geriatrics. And I'm not going to discuss insulin just because we don't have time, but I can answer questions about insulin if you want me to. Okay, so what drugs do we have to treat diabetes? These are the classical ones. The most, well, they're not the most frequently used anymore, but they are the oldest ones. Those are the sulfonylureas, glyburide and glipizide. They've been around for many, many years. They're very effective. There's no drug that is more effective than sulfonylureas. And they work on the pancreas. They don't make the pancreas work more. They just kind of push it and tell the pancreas, well, you still have some insulin there, so go ahead and release it. But the problem is that the insulin is released in an uncontrolled fashion. So that's why patients on sulfonylureas have a risk of developing low blood sugar. There are some drugs that block the absorption of carbohydrates in the gut, but we don't use them very much, and that is acarbose. It's not very potent, so in the US it really didn't took off, but it is used a lot in Europe. Metformin, which is probably the drug of choice in general in diabetes, because, and I'll explain why, but it's a pretty effective drug and very safe. It works mainly in the liver by making the liver produce less glucose. And we have other drugs that work in the liver too. Rosiglitazone, which is hardly used anymore, and pioglitazone, which is still used. There's drugs that improve insulin sensitivity in mainly muscle, such as metformin and pioglitazone. And there are newer drugs that work on a system called the incretin system. One group of drugs is called DPP4 inhibitors, such as sitagliptin and saxagliptin. Their commercial names are Januvia and others. And there are other drugs that work, they're called incretin mimetics, such as exenatide and liraglutide and others which are injectable. These are injectable, these are oral, and they are in the market. So sulfonylureas, as I said, they are being used for a long time. They are effective. One problem with them is that they cause weight gain, and they can cause hypoglycemia. There are different ones. Chlorpropamide is not in the market anymore, but the other ones are glipizide, glyburide, and glimepiride. With aging, the main thing is that half-lives of all these drugs increases. So older people, the effect of these drugs is more potent. So we should use if we're going to use it, we should use the one that has the shortest half-life, and that is glipizide. In young and middle-aged people, glipizide is usually used twice a day, but in older people, it should be used only once a day. Metformin, it's also very effective. We like to use it in overweight people because it doesn't cause weight gain, and some people lose weight. If it's used alone, it won't cause hypoglycemia. Some precautions, and that is that in rare cases, very, very, very rare cases, has been associated with lactic acidosis. And that usually happens in people with kidney failure and that have other medical problems. So metformin should only be used in people that have a creatinine. If it's now in women, it's 1.4. In men, it's 1.5. However, these numbers based on creatinine do not apply if a person is over 80 years old. And that is because older people have smaller muscles. And the creatinine value in the blood is really a reflection of, one, the kidney function, but also the size of our muscles. So an older person might have a normal creatinine of 1.2, but if that person has smaller muscles, that creatinine of 1.2 is probably false, and that person might actually have a true level of 2.8 or 3 or something. So for people over 80, it is recommended to do a formal measurement of creatinine clearance and only give them metformin if it's normal. Okay. Other contraindication is, of course, congestive heart failure and severe kidney, liver disease. So this is often misinterpreted. People over 80 can take metformin, but the only thing is that a formal measurement of creatinine clearance, a formal measurement of renal function should be done. Okay. The PPAR gamma agonists, pioglitazone and rosiglitazone, they work mainly in muscle and liver. They are pretty effective to decrease A1C. Some problems. Well, actually, let me go back to metformin because there's something I want to say about weight. So, of course, most of our type 2 diabetic patients are overweight, so losing weight is a desirable thing. But as I said before, many of our older patients have type 2 diabetes, but they're not necessarily obese. And many of them actually are malnourished. And you see this in nursing homes, people that have type 2 diabetes, but they're not eating well. So giving them a drug that can cause weight gain and decrease appetite might not be the best choice. So metformin is probably the drug of choice, but just be careful because it can decrease appetite. So many of our elderly patients have problems with appetite. You don't want to give them metformin, okay? Now, in most of our patients, as I mentioned before, are overweight, so giving them a drug such as pioglitazone is probably not the best choice. And some of them don't mind the increase in weight as long as their diabetes improves, but there's a lot of people that are bothered by the weight gain. Okay, but in older patients, particularly the ones that are thin and have decreased appetite, actually these drugs might be helpful because it will help them with their weight. They very rarely cause hypoglycemia. They are effective in older people. Contraindications, people with elevated liver function test. If a person has edema or congestive heart failure, do not use them, okay? It's totally contraindicated. Some newer things about these drugs, with rosiglitazone, because it can increase LDL, and there have been some associations, although weak associations with cardiovascular events. The use of rosiglitazone has decreased significantly, but pioglitazone still, it's out there. There are some studies associating pioglitazone with the development of bladder cancer, and you've probably seen that in the news. The FDA is monitoring this, and at this point, I'd say that the evidence indicating that pioglitazone leads to bladder cancer is very weak. What I would say, if you have a patient with a history of bladder cancer or a family history of bladder cancer, don't give him pioglitazone. Someone with, who has hematuria, don't give him pioglitazone. Or if someone who's taking pioglitazone develops hematuria, check him for bladder cancer. But at this point, the FDA has not really, and they've been monitoring this very closely, have been able to determine conclusively that it causes bladder cancer, and at this point I am still using it, albeit with caution. Something that there's probably more evidence is that pioglitazone can decrease bone density, and there's a small increase in bone fractures with long-term use of pioglitazone. So if you have a patient with osteoporosis or decreased bone density and you're trying to bring up their bone density, probably pioglitazone is not the best choice. Some of the newer drugs, that the ones that work through the incretin system. So what is the incretin system? Our gut, after we eat, releases several hormones. One of them is called GLP-1. This hormone does many, many things. One of them is that it goes to the brain and it suppresses appetite. This hormone, which is made by the gut, also makes the pancreas release more insulin and delays gastric emptying. So overall, GLP-1 has beneficial effects on glucose control because people eat less, they release more insulin, and the emptying of the stomach is slowed down. And it does not cause hypoglycemia. So of course, the drug companies, when they discovered this, which actually was discovered in the saliva of the Gila monster, and that's how the Gila monster kills their prey. When they discovered this, well, this is a great diabetes drug, but it turns out that its half-life in the blood is very, very, very short. So they came out with medications, agonists that work just like GLP-1, but they have a very long half-life, and that is exenatide. It's Byetta. The other group of drugs are drugs that block this enzyme. This GLP-1 enzyme is cleaved, it's broken down in the circulation by this enzyme called EPP4. So if you use an inhibitor of the enzyme that breaks down this, then you have more of this in the blood. So that's the other family of drugs, inhibitors of DPP4, and they're shown here. The agonists of GLP-1 are exenatide and liraglutide. These are the effects I mentioned already. They tend to cause significant weight loss, so they're not approved for weight loss, but a lot of people do use it for that. They don't cause hypoglycemia if they're used alone. The main problem is nausea. About 1/3 of patients do feel nausea. So if you have an older patient that's not eating well, you're probably not going to give him exenatide. It's injectable. Exenatide, it's injected twice a day, although there's a new version that's once a week. And liraglutide is once a day, okay? They work in elderly, but of course you have to be cautious with their side effects, and they're very efficacious. These are the DPP-4 inhibitors. They're all oral. They're given once or twice a day. The good thing about them, they're very safe, they're very well tolerated, they virtually don't have side effects. The main problem, they're not as potent as these drugs in terms of reduction of hemoglobin A1C. So if you have a patient with very mild type 2 diabetes, this is a reasonable choice because they're very well tolerated and they work very well in older subjects. Now, I'm going to go through some cases and you'll tell me what drug would you give to these patients. Case one, and all of them, these are real cases I had. This is a 70-year-old man, type 2 diabetes since mid-50s. He hasn't seen a doctor in 4 years. He used to take glipizide, then insulin, and then the last 6 years, he's like, I don't take anything. He drives a truck. He distributes produce around the city. He has some hypertension, and sometimes he takes his hydrochlorothiazide, sometimes he doesn't. He's overweight. His blood pressure, it's a little bit elevated for someone with diabetes. No retinopathy, no neuropathy, and just a little bit of swelling in the legs. He's happy as a clam, very active, and just goes around with his life like nothing is wrong with him. Normal creatinine, urine albumin, maybe a little bit increased, but nothing too bad. His A1C is 9.7, so clearly his diabetes is poorly controlled. Glucose 289. LDL is highish for someone with diabetes. HDL is low. So how aggressive would you be, and what diabetes agent would you use? Remember, he drives a truck, and he's a happy man. He's had a happy life. Who would give him insulin? Good, no insulin. Who would give him a sulfonylurea? Correct, no. No one wants a person on a truck with hypoglycemia, right? Who would give him pioglitazone? Well, pioglitazone would work. The only reason I wouldn't, but pioglitazone would work, is that he's already obese, and pioglitazone will make him more overweight. Who wouldn't do nothing and say, bye-bye, see you? Okay, so someone would not. And that's not a totally unreasonable thing. The only thing is that, as I mentioned before, his glucose is 289. It's not too far from 300 or 400, which is at a point which can make him dehydrated and bring him to the hospital in a few months. So I would do something to decrease it. Okay, I'm going to get to that. So what would you guys do? Exactly. So metformin, as I mentioned, is the drug of choice. He doesn't have kidney problems. It's going to help him with his weight, will not cause hypoglycemia, so he doesn't have to be checking his sugars that much, and he won't be passing out in the middle of the road. And that will bring his A1C probably close to 8.5. So metformin would be a good choice. Probably metformin plus a DPP-4 inhibitor. They seem to work fine, and none of them cause hypoglycemia, so that would be a reasonable choice. Okay, let's go with the next one. 76-year-old lady with type 2 diabetes with osteoporosis. She takes alendronate for that. She's very active. She has a very active social life. She is BMI of 22, so she's not obese. Her blood pressure is a little high. She does have a few microaneurysms in her retina. She's thin, some muscle wasting, normal kidney function, but she's leaking protein in the urine. Her A1C is a little, it's high at 8.1. Normal cholesterol, GAD negative. This means she does not have type 1 diabetes. So how aggressive should we be, and what diabetes agent should we use? So she's 76, but she's very active. She goes out with her friends almost every day, and she wants to live many, many years. So who wouldn't do anything? So no, I mean, she's 76, but as I said, we don't focus so much on the age as much as in cognitive function and as life expectancy. Who would give this person metformin? Yeah, so metformin is not a totally unreasonable thing, and one could potentially try it. The only thing is that she has some muscle wasting, suggesting that her appetite is not great, and metformin can decrease the appetite. Someone might give insulin, and again, is not totally unreasonable, but at this point, I think that there might be oral agents that could be used. Now, should we be more aggressive than the previous gentleman? I say yes, because the previous gentleman seemed to be protected. Remember, he's had diabetes for 50 years and didn't have any complication, whereas this lady already is leaking past microaneurism. So we do want this lady to have an A1C closer to 7 or lower than 7. So normal is considered under 6.5, but the recommendations is to avoid complications is to have it under 7, closer to 6.5. How about pioglitazone? So actually, pioglitazone is not unreasonable because will decrease her A1C, will not cause hypoglycemia, will actually make her a little bit of weight. And actually, when I made this slide, my answer was pioglitazone. But it's not until the last year in which this issue about osteoporosis came up. So I might be hesitant of giving her osteoporosis. So I would probably give him something like a DPP4 inhibitor, which will decrease her A1C closer to 8.1, closer to 7.5. And perhaps in combination with a low dose of metformin, if that doesn't affect her appetite, or a low dose of pioglitazone. But, okay, then this is the last one.
Actually, just that time.
Can I do this one? 30 seconds. 68, type 2 diabetes, end-stage pulmonary fibrosis, on home oxygen therapy. She takes Glargine, 15 at bedtime, and Lispro 3 times a day. She lived with her daughter. Her daughter came with her in a wheelchair. BMI, she's very thin. Oxygen saturation with oxygen 89%. No retinopathy, no neuropathy. Her A1C is beautiful. Her glucose is 92, normal cholesterol. Her daughter, very lovely, says, I check her sugar 4 times a day. I give her meals so her sugar doesn't go up. I don't want her diabetes to go up. What would you say? Leave her alone, correct. So I told her this lady, you know, she probably should enjoy life. She just has a few more months left. So don't check her sugars, let her eat whatever you want. Just check her sugars once a week, make sure she's not getting very decompensated, and if her sugar goes over 300, just give me a call. And thank you.